Hey, there's Nick. You got right in, right?
Yes, I'm ready, John.
Okay. This is the first time I've seen you with a shirt on. Did you hear me, Nick?
Yes, please.
It's the first time I see you wearing a shirt. Okay, we don't start for 12 minutes.
How many? 10 minutes?
12 minutes.
4. Okay. Okay, John. This is a new beginning for me, eh?
I
Please
know,
consider
I'm excited. I'm excited. Okay.
I'm also excited, and I want to thank you very much for your friendship, and let's hope it will be a new collaboration. Okay.
Well, it's good for you to get involved, you know, to be part of it. I think you're gonna feel better.
Okay, John. Thank you very much. Thank you very much for everything.
Okay, what you need to do, okay, you just say hi. Hold on, let me,
Okay.
you need to say hi, I'm Nick and describe your hospital, your training, your background. And then you'd like to introduce Sarath
The speaker.
Munasinghe from Nepal. He's working at this hospital. He's specializing in this. He's a neurosurgeon from Sri Lanka. Now, do you want to get a background? You see your background? You know how to put a background on your screen?
Okay.
Do you know how?
To present the speaker, yes, I know how.
No, do you know how to put a background? You see my background now?
Yes, I'm seeing. Okay.
Yeah. Well, I can change it. Well, first let me put my camera on.
I'm not able to change my background.
Yeah, you see, I can change the background. I go to the camera at the bottom of the screen. There's a menu, open it up. And
yes. Okay, is this John? Is this possible to do it in the next presentation?
Yeah, we'll do it the next time. Okay. Okay. See, but you see how I am changing my background. But now I'm going to change it to the most appropriate. This one, and I can email you a background like that. And what you do is you go to the bottom of the screen, go next to the camera, open up the menu. You see the menu next to the camera, open it up.
Yes. Choose virtual background.
Yes. I'm going to send you the background to put, okay? Let me show you. Hold on. Let me get it. The wonders of computers. Okay, Nick, I sent it to you on Facebook. Okay, download that image. And then you go to the choose virtual background. And you click on the, once you, did you open that, choose virtual background? You gotta click on the plus, there's an add image, there's a plus. Are you on that screen now of virtual backgrounds? There's a plus to add an image.
I will try to do.
Okay, add the image and you hopefully you downloaded my image I sent you. Hello, Sarath.
Sorry, I was a bit late because I'm not feeling very well today.
I can't hear you. I can't hear you.
Can you hear me now?
Not very good. Not as good as I usually can.
Can you hear me now, John?
Yeah, now it's good. Now that's really good.
Yeah, it was a very, very busy 2 weeks and not feeling well as well.
Oh,
So-
boy, okay. Well, we're gonna have to pay,
Hello,
we're gonna have to
dear
pay you more
colleague.
extra.
Sorry?
We're gonna have to pay you extra. Okay, I'd like you to meet Nick. He's a
Yeah.
neurosurgeon from Greece.
Hi, Nick.
Hello,
Nice to
dear
see you.
friend. It's nice to see you. Dr. John Bennett asks me before half an hour to present you. And because we are very friends with John and we know each other through Neurosurgical TV for 4 or 5 years or even more, I accept. I read from LinkedIn that John sent to me your CV, and I will introduce you. Okay.
Thank you very much for joining.
Yeah, Nick is very
Okay.
active. He comes to a lot of webcasts. And now we're trying to get him involved.
Yeah, of course. That's a
So,
good move. So
Yeah,
you
it's
can
good to get-
join and we can have a open discussion. So I think we can use this platform as a very interactive.
It'll get
spine-
better. It'll get
Yeah.
better. I'm dedicated to doing this. I'm not going away. I'm staying with this. And we're making
That's great.
progress. We're getting a lot of big webcasts now. But not necessarily the big ones. The small ones are good. This is gonna grow. The more we get people involved, it's gonna grow. So I'm convinced.
We have some common friends, dear Surat, such as Andreas Dimitriadis and Nick Gerakis. They are also good friend of mine.
All right.
And, okay.
Good to hear.
Let's
So-
get
dear
your
John,
background on there, Nick. Excuse me.
I didn't manage to do.
Okay, well, all
Yeah.
you do, I can lead you. Just go open the menu. Open the menu. We'll get it done. Just open the menu. Go to choose virtual background. Are you on that screen now? Choose virtual
Virtual
background.
background.
Okay, go to
Yes.
the far right. There's a plus mark. You see the plus?
Add image.
Yeah, the plus mark. It says add image.
I don't know.
Okay, you see
what
virtual
image-
background, video filters. Don't do that. To the far right, there is a plus mark.
Yes, I saw, but I don't know how I put the image
Okay,
before that
click
you
on the
sent to me.
plus. Click on the plus. You click on that
Yes,
plus.
yes, okay, I will do now. Okay.
Click on the plus and it says add image. You got that? Add, click on the plus. It
Yes, yes,
says-
okay.
Okay, add image, and then you can go on your computer and pick the image you want.
The important is to take your image, no, and not the other.
Oh, don't, okay, we'll do it later then. Don't worry about it. If you have a revelation, just let me know.
I'm not able to find the image, okay.
To me, this seems like a very interesting topic. I'm not a neurosurgeon, but.
I
Former
found
orthopedist.
it. I found it.
Oh, you got it. All right. Look at Nick. Nick did it. You're not, Nick, you're now I have to pay you.
I want only your friendship.
Okay. Well, I like employees
I
like that. That just want my friendship instead of a
I
paycheck.
have your friendship, and this is the.
That's enough.
This is
Oh
a
man,
very
I'm gonna have to use
important
you.
thing.
You're gonna have to head the accounts.
What time we have to start?
A few minutes. Don't worry,
Okay.
Sarath, we'll get people coming. A
Okay.
lot of people come late. We'll wait a few minutes.
Sure. Nick, are you a neurosurgeon, mainly specializing in brain
Yes,
surgery or spine
I
surgery?
I'm neurosurgeon and also pediatric neurosurgeon. I do general neurosurgery, but much more brain neurosurgery, but also spine.
Okay.
You know, in my country, perhaps also in yours, you have to do everything, more
Yeah,
or
same
less.
here. Same here.
Right now, I'm blasting it on WhatsApp. Before we start, okay?
Surat, in
Yeah.
your titles, the member of the Royal College of Surgeons, I know, the FEBS, I know. The first MBBS, what is?
That is fellow of the
Member of-
European European Board of Neurosurgical.
No. I know that the first, the MBBS.
Right, MBBS. Yeah, that is the basic degree for the Bachelor of Medicine and Bachelor of Surgery.
What is What is member of MB? What is basic?
Yeah, Bachelor of Medicine, Bachelor of Surgery, MBBS. So it comes.
Okay.
Yeah, next from Smirnos, Smirmos, right? That's your name, that your last name. And you're from the north of Greece, right, Nick?
From Thessaloniki, yes.
Thessaloniki's.
Yes. Thessaloniki. Should we start or we have to
Yeah,
wait?
you ready to go? Okay, let's start. Okay.
Hello, everybody.
Let me introduce you first, Nick, okay?
Okay.
Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett broadcasting from beautiful Miami Beach for Neurosurgical TV. We are honored with the presence of Sarath Munasinghe, who's going to present for the Neurosurgical Grand Rounds of Sri Lanka. And we have a special host, a gentleman that's been following the channel for a while. He's a very active participant, and tonight is his first night of hosting. Welcome, Nicholas, from Northern Greece.
Thank you very much, dear John. It's a great honor and great pleasure and great satisfaction to be the host because today we will present the Sri Lanka Neurosurgery Grand Rounds, and we have a distinguished guest, also a magnificent neurosurgery, a spectacular neurosurgeon, and a great friend, such as Dr. Sarath Munasinghe, that is a member of the Royal College of Surgeons, fellow of the European Board Neurosurgical Society. He is a board-certified neurosurgeon with a demonstrated history of working at distinguished neurosurgical centers with eminent neurosurgeons, and his practice general neurosurgery with special interest in spinal and neurovascular neurosurgery. He's consultant in teaching hospital of Ratnapura, but in the past he was also consultant neurosurgery in teaching hospital of Batticaloa, and has various great experience in UK, such as in neurology and neurosurgery Queen Square in London, in King College Hospital, NHS Foundation, and also has a great experience in all the field, in the whole field of neurosurgery. Dear friend, dear distinguished colleague, we are very happy to hear your exceptional presentation. Thank you very much.
Thank you very much for your kind introduction, Nick, and we welcome you on board on behalf of Neurosurgery Grand Rounds, Sri Lankan Grand Rounds. I'm happy to have you on board, and thank you very much, John. So as usual, let's start with the presentation. I hope everyone can see my screen.
Yes, we can see it. Not full size yet.
Right.
There we go. Perfect.
Right. So today the topic is, I have chosen this topic, cervical facet dislocation, mainly concentrating on bifacet dislocation because it's a controversial entity, and we can discuss on the few facts which are controversial on the topic. So I have specifically mentioned Sabaragamu chapter because I'm representing the Sabaragamu province of Sri Lanka as this one and only neurosurgeon from the Sabaragamu province, Ratnapura district, where I'm working at Teaching Hospital Ratnapura. So I am presenting my cases, which I have done within the last year. I'm showing you all these cases I have done during the last year from the patients presented from this province. And I'm not representing the whole country because, you know, the ideas and the opinion of each and every neurosurgeon might differ, even though the principles are the same. So let's talk about facet dislocations a little bit. I'm not going to talk much on the facts and the theoretical aspect. So what I'm going to do mainly today is to discuss the implications, the practical, the aspect, the implications, especially when you are working as a neurosurgeon in a resource restricted country, restricted area. So how to tackle with these type of difficult situations. So we all know the definition of bifacet dislocation. So mainly I'm concentrating on the bifacet dislocation, and we'll discuss a little bit on unifacet dislocation. So we all know that we don't have a perfect guideline on facet dislocations, especially bifacet dislocations. And one could say almost no treatment guidelines. And there are multiple factors for us to consider when choosing a treatment approach. And it is highly variable. So the management is highly variable with these few guidelines. So some surgeons, if I ask regarding the management, they have their own way of managing these facet dislocations. Although, I mean, there are certain guidelines that we can rely on reliably. So whatever it is, even though we have this level 4 data to guide the treatment, so only suggestions can be made, but we always need to follow the principle as the safety of the spinal cord first. So whatever we do, we need to keep in mind that it's the prime, the importance is the safety of the spinal cord first. So when we talk about the treatment decisions, as we all know, the treatment decisions can be affected by these following factors, such as the neurological status of the patient, which is very important, which affects the treatment decision of the surgeon, and whether there is a disc herniation or not, and the classification of injury, whether it is unilateral or bilateral, and also the surgeon experience, and whether the surgeon is comfortable with the open reduction techniques, MRI findings, and whether there is any end plate fracture or a facet fracture, and the body habitus of the patient sometimes, and also the injury level, the injured level. Right, so I have selected few controversial areas. So we'll talk on that. We'll have a very quick discussion on that. So the place of closed reduction, especially in these following categories: when the patient is intact neurologically, when the patient is having incomplete neurology, and the patient is having complete injury. So whether to reduce first or not, and also regarding MRI, when to obtain an MRI, whether it is prior to reduction or after the reduction. But now when you consider people like us, it is not all the MRI, talking about MRI, it's not always available for us. So I had a few years in my career that there was no MRI in my hospital. So I had to rely on the CTs and the X-rays and to decide depending on the clinical picture. So it's not always feasible, it's not always available. So you had to decide accordingly. So I think considering all these facts and depending on what we have experienced, this is my perspective regarding the reduction and regarding the MRI. So if the patient is presenting with a complete injury, I believe there is no harm in trying urgent closed reduction before an MRI, because there is nothing for us to lose, because the patient is having complete injury. So I think in that case, we need to go for a closed reduction as early as possible. So if it is successful, then you have the time to go for MRI and to decide on surgery. If not, if the reduction is unsuccessful, either go for an open reduction urgently. And if you are going for open reduction, usually we prefer anterior, or you can do an MRI if you can get it done as early as possible and then determine the approach. For patients presenting with an incomplete injury, I think, again, there is a place, I think we should consider closed reduction if the patient has no contraindications. And if it is successful, all right, go for MRI and go for surgery. If failed, say for example, if the reduction is failed, then the question, what are we going to do? Are we going to do an MRI, or are we going to go for an urgent open reduction? So these two options, so there is a little bit of controversy again, a gray area, either to go for urgent operation, urgent reduction. Usually we prefer anterior approach, or go for an MRI and determine approach. I think you had to decide depending on the circumstances, considering your environment, you had to selectively decide on that aspect. So talking about close reduction, we all know. So we are trying this, and we do the close reduction whenever it is possible. But sometimes doing an urgent close reduction is not feasible, especially when the patient is unstable, presenting with spinal shock. And in my practice, usually these patients present to us at night, so mainly due to motor vehicle accidents. So if the patient is presenting at night, say, for example, midnight, and we have only 4 or 5 hours for the next day, so we can go for an open reduction, we can go for an open surgical reduction, then I don't think that there is no hurry for you to go for a closed reduction, and there won't be much difference in going for a closed reduction or going straight away to open reduction after de-optimizing the patient. So usually in my practice, what happens is we get most of these patients at night, so we do the open surgical reduction next day early morning. So the surgery is done within 24 hours, but in some occasions we have done the closed reduction as well. So what is this controversy about the closed reduction? That is because of this fear of a herniated disc following this studies. But now we know that there is no such increased risk of getting extrusion of the disc, even though there is there is an extruded disc. The neurological deterioration is not, that big for us not to consider the closed reduction. So this is the AO guidelines. I usually follow AO guidelines, and this has been taken from the AO guidelines regarding bifacet dislocations. So they recommend they recommend the closed reduction first if there is no contraindication. So if the reduction is successful, and then it depends on whether there is a disc herniation or whether there is no disc herniation. So if there is a disc herniation, if it is unilateral, anterior approach is enough according to them. And if it is bilateral, we do 360-degree, both anterior and posterior. And if there is no disc herniation after successful reduction, once the MRI is done, if it is unilateral, go for an anterior approach only. And if it is bilateral, again, you can here, if it is bilateral, although it's bilateral, if there is no disc, they recommend posterior instrumented fusion only. But I know It depends on the surgeon, because some might go for a combined anterior and posterior approach as well. And if the reduction is unsuccessful, again, depending on whether there is a disc or not, if it is unilateral, again, anterior approach. If it is bilateral, 360-degree, no disc, unilateral, anterior approach, bilateral, again, anterior approach only. So you can see the tendency or the trend is to mainly go for anterior approaches rather than posterior approaches. So now we understand the overall, the studies being done so far recommend the anterior only approach in most of these cases, or anterior plus posterior approach rather than just the posterior approach only. But you know, it's sometimes when you work in a resource restricted environment, you might have to change your decisions, and you might have to take the decisions sometimes depending on the resources available for you, and depending on the some various factors, as we discussed earlier as well. So a little bit of regarding the methods of reduction. So we all know that these are the methods of reduction available. So as we mentioned, we do know about awake traction. We can do traction anesthesia as well. So the segmental distraction, so Casper pins. So these are both closed and open reduction methods that we commonly use. So let's talk about something about which approach. So as we discussed, whether it is anterior or posterior. So there are so many advantages of anterior approach. So we all know muscle trauma is less, and there is anterior load sharing is better, can do the disc removal because of the less muscle trauma. The infection rates are low, post-operative pain is less. So the direct decompression of the spinal canal for the surgeon, and also the morbidity is low, and the patient positioning is also easy. So regarding the posterior approach, the posterior approach is we have a better control, and the manipulation is facilitated by fixation. We can drill the facets, and we all know the biomechanically it is considered more superior and more strong than the anterior approach, and also it is helpful at certain levels such as C6, C7s, and C71 at the junction mainly. So this is from the studies that we know. Although we talk about the pros and cons, we know there is no significant differences with regard to fusion rates, alignment, neurologic recovery, or long-term pain relief in patients treating with either the anterior or the posterior fusion and instrumentation. And some special facts, few important facts. If there is an end plate fracture or a facet fracture, which in association with the bilateral or unilateral dislocation, it's an alert to the surgeon that there may be a risk of radiographic failure if you do anterior plating only, and either a posterior fusion or a combined approach need to be considered in that type of situation for the greatest stability. Right. Again, a few facts. So if you are going to do the reduction only posteriorly, you have to make sure that there is no disc material at risk that could potentially lead to cord compression and neurological deterioration, even though the percentage is low, even though the percentages are not that high as we thought. And right, so posterior reduction we done in the prone position, and sometimes, you know, it's sometimes difficult to obtain a good control distraction. Right, so this is something about anterior open reduction. So I think I don't need to go in detail, because as neurosurgeons, we all know how we do this. So close reduction, with Gardner-Wells tongues and open reduction. Usually we use Casper distractor pins. Sometimes we use the laminar spreader. And most of the time we can achieve a successful reduction from the anterior approach. But sometimes, especially if it is closer to the junction, if it is C6, C7, sometimes it is difficult to get the appropriate, the correct reduction only through the anterior approach first. So in 25% of the cases, the anterior open reduction is going to fail. So it has happened to me, and in that case, we had to go for the posterior approach. Right. So if you start from the anterior approach, and the anterior approach is failed, the reduction is failed through the anterior approach, and there is something called the buttress plate, which is described by Allred and Sledge. So you can use a buttress plate. So this is what you call it. So you do the discectomy first, prepare the end plate, and just get a graft or whatever, the ilia cresto, the allograft, and place in the interspace, and just hold it with the buttress plate, and just screw it in two places, only in the superior vertebral body. And then you close the wound and go to the posterior aspect and do the posterior surgery. And you can make sure that with the X-ray you can see the whatever the graft is pulled into the space, and without impinging on the spinal cord, and the screws in the buttress plate did not pull out of the superior vertebral body. So it prevents a third time turning off the patient and going in what we call anterior, posterior, and again anterior. So we can avoid that, and we can just do anterior and posterior. Or otherwise, if the anterior approach is failed, you go posterior, but you then again you have to come back to the anterior and do the fixation, the fusion. So I haven't tried that. So these are the methods of anterior reduction. So I follow the AO guidelines. So as mentioned before, I follow the guidelines, and I perform and proceed according to that guideline. So my preferred approach is anterior first. So I try to reduce after the discectomy, try to reduce the dislocation. And I don't have the laminar spreaders. We only have the Casper distractor pins. So sometimes it's a bit difficult, especially in locked facets bilaterally, to achieve a successful reduction. So in that case, you have to go to the posterior approach, go for a posterior approach, and then again come back to the anterior approach, which has happened to me in twice. So using the laminar spreader, different techniques of reduction. So this is posterior reduction.
Dear Surath, may I interrupt you?
Yeah.
It is very interesting what are you saying, but this thing, the posterior approach and the combination between anterior and posterior approach depends also of the how many cases a surgeon can perform, about his surgical experience. This is the important issue to say.
Exactly.
Okay, if you are experienced enough, if you are not experienced, you can do also posterior approach. If you are experienced, you can do complex approaches. Is this right? A comment about that.
Yeah, exactly. That's great. So I will show you as we go along with the rest of the presentation. So this is the posterior approach, and this is the reduction techniques in the posterior approach. We know it is not that difficult with the posterior approach. You can drill the facet, so it's not that difficult with the posterior approach as well. So we talked about this. So We know about the complications and the reduction rate. Sometimes there can be delayed instability. Some people do present with delayed kyphotic deformity, the graft failures and displacement, right? So the mortality, the vertebral artery injury, all these things we had to concentrate, we had to think about, consider. So keeping all this in mind, I will show you some of the cases I have performed during the last 10 to 12 months at this hospital in the patients from this province. So as far as I'm concerned, I have done somewhere around 16 fracture dislocations, which is quite a, big number considering a peripheral hospital. So I have selected few cases, and out of that, so I'm going to show you a few cases and we can discuss on the cases. So this is the first case. So I'm going to show you the first few cases where I have done both anterior and the posterior at the same time and on the same day. And I need to mention that we have seen these cases, and we know a patient presenting with bilateral facet dislocation, if the patient is having complete neurology, as we know, 90% of the patients have severe neurological disability. Out of that, 75% complete neurology. So it's a devastating injury. It's a devastating injury. So most of the time, patients in our setup, they suffer or they succumb to that, not because of the cord injury itself, but because of the complications, mainly due to aspiration pneumonia. So all these, all sorts of complications they get, bed sores, infections, and aspiration pneumonia, deep vein thrombosis. So it's actually, their life becomes miserable. And most of the times we have seen that the neurology does not improve with time. Most of the time they're paraplegic or either tetraplegic. And most of the time in my setup, they end up with the tracheostomy because of pneumonia and the respiratory complications. If you see all the studies, almost all the studies, they say the common complication is pneumonia. So in a country like Sri Lanka, where there is no proper rehabilitation pathway, no proper rehabilitation system, it is really difficult for a patient, especially presenting with bifacet dislocation and having tetraplegia, complete paraplegia or tetraplegia. It's extremely difficult to manage in my setup, in our setup, because the rehabilitation system is not good at all. So it's a big burden to the country. So we have seen, however much we do anterior surgery followed by posterior surgery, 360-degree, maybe take around 4 or 5 hours. But patient's outcome, when you consider, it's not that great. So with time, we have experienced, we have realized, we have learned that in some cases, now, for example, if a patient comes, I only consider 360-degree fixation for the patients with at least Asia B or C, Asia C or D, or sometimes Asia B, I consider if the patient is young. If the patient is old or if the patient is Asia A, I don't want to go for, a big procedures like 360-degree fixation. I just do either the anterior approach or the posterior approach according to their guidelines, but selectively and depending on the circumstances. One reason, thinking about the outcome. The second reason, sometimes we had to consider the poor resources as well, because sometimes the patient can't afford the hardware. So in that case, I have no option. So I have to use whatever the resources available. So let's see how I have tackled the situation. So this is the first case, 25 years old, army soldier, motor vehicle accident, Asia B. This is the CT he presented with. You can see 2, 3, 4, 5, 5, 6 dislocation. He was Asia B. And this is the MRI. And you can see the disc as well. So anterior approach followed by the posterior approach. And this is a big build, 90 kilogram, big built man, a young patient. So decided to go do 360-degree at the same setting. So I had to use a fibular graft because I did not have appropriately sized ACDF cages at that time. So I had to use the fibular graft. I usually don't like to take iliac grafts. I think fibular graft is better than that, according to my experience. So I used that and then turned the patient and did the posterior. So we got a good reduction in the alignment. Is the post-op CT, right? So this is him. So as I said, most of these patients, 90% of these patients, they do develop respiratory complications post-operatively. So in this patient also, he developed pneumonia. So we had to put him on a tracheostomy. But unfortunately, at 3 months' time, his neurology did not improve much. And he died after 4 months post-op due to persistent respiratory infection and followed by sepsis. Right. So another case, 44 years old male, fallen from height. We get these type of cases, fallen from height, fallen from trees. It's very common in my area where I work at the moment. Again, this patient, Asia B. So I did the anterior followed by the posterior on the same day. So this is what he presented with, 2, 3, 4, 5, again 5, 6 dislocation. So again, the CT shows 5, 6. I didn't have MRI on, for this patient. So anterior discectomy, reduction, and then the plate, followed by the posterior approach with the lateral mass screw fixation. And this patient had improved from Asia B to Asia C after 3 months. So this is the CT post-op. I usually do posterior decompression in this type of patients. I routinely do. So this is the this axial view. Sorry. Okay. Another case, again 360-degree approach because relatively young, fallen from height and Asia C. So that patient, so again we did the 360-degree fixation, anterior followed by posterior fixation on the same day. So this is the CT he presented with 2, 3, 4, 5, 6, 7, 6, 7 dislocation. I don't have, unfortunately, the sagittal cuts of this the post-op CT, the sagittals. I'm only having the video of the axial. That patient, I had to go for this expandable cage. Right. Another one. This is severe. One of the very severe injuries I had encountered. A young one, again, fallen from a height, fallen from 40 feet height. presented with this injury, with the burst fracture at C5, with some vertebral artery injury as well. So this patient again presented with, I can remember it's Asia C. So we did, he's a relatively young patient. It's not relatively, it's a young patient. I think it's 31 or somewhere else. So we had to do the, I did the anterior approach with the corpectomy, and followed by the posterior fixation on the same day. You can see the superior screws, they had come out after the surgery. So, and again, unfortunately, this patient died due to pneumonia. So that's what I'm saying. So whatever you do, I mean, the post-op complications are very, very common in this type of patients. And so you have to be a bit selective, thinking about all these things. And most of the time what we see is that we are unable to wean off these patients from the ventilator. So, and we have the problem of the issue of lack of ICU beds as well. So so these patients, we had to do early tracheostomy and send to the wards, and then these patients are not properly managed as in ICU. So all these complications set up, and ultimately leading to a devastated complication and a very poor outcome, whatever you do. So therefore, I have decided first to discuss with the patient's family when these type of patients come to us. So depending on the neurology of the patient and considering all these facts, the age and the comorbidities. So if the patient is having a good prognosis according to our experience and according to the literature, what we have learned, then we give them the option. So in that case, we are more happier to go for a 360-degree fixation. But if that is not the case, then I believe, I think what is appropriate is the quickest and the strongest construct for that patient. So where the biomechanical stability is maintained, so he can at least lead a life where he can move rather than doing nothing. So this is another case of 360-degree fixation, 58 years old male, again fallen from a tree, 30 feet height. He was Asia A with an incomplete neurology. So these type of patients, we are happy to operate within 24 hours and do what is said, what is mentioned in the guidelines, go for both anterior and posterior on the same day. And he improved. He improved. He had a Asia score, I mean, Asia motor score of 2 after 2 months. So you can see 2, 3, 4, 5, 2, 3, 4, 5, 6, 7. Again, bifacet dislocation. So regarding the timing, and also one has to remember, I mean, when you are doing anterior and posterior approaches on the same day, you have to think about the duration of the surgery as well, because most of the times we know these patients presenting with spinal shock. So we never operate on a patient with a spinal shock. We treat the spinal shock first, and we let the patient to become stable. Once we stabilize the patient, only then we go for surgery. So we always try to maintain a high blood pressure, adequate blood pressure. And then we decide on surgery. Sometimes, you know, it's very difficult to treat, get rid of these initial unstable stages. So, and also remember what I was talking about is regarding the timing. So you have to be quick as well. I mean, you can't take 8-9 hours. If you are taking 8-9 hours for both anterior and posterior approach, I think it is better to do it at a stage procedure rather than risking with increased intraoperative timing. So for example, I can tell you, we started this case at 9:30 a.m. in the morning. So we get these patients at 8 o'clock, but anesthetists take around 1 hour to insert the CVP lines and the arterial lines. So this is the time we usually start the case. So this is at the beginning, we get the x-ray. And this is, you can see after both the anterior approach as well as the posterior approach, it's almost 2 o'clock. It's for 4.5 hours, but you understand, obviously there is a gap when you need to turn these patients prone. So it takes another half an hour. So roughly for me, it takes around 1.5 hours for the anterior procedure and 1.5 hours to 2 hours for the posterior procedure. So within 4 hours, 4.5 hours, you can complete both the anterior and the posterior procedures. I think it's a reasonable time period. So yeah, and that patient improved with regard to the neurology, although we had to go for tracheostomy in that patient as well. So this is after 1 month, his upper limb improved, and this is at 3 months. The tracheostomy was closed, and still he had some swallowing difficulties, and he was with an NG, but he improved a lot compared to what he presented to us at the beginning. So as I said, those are the few cases where we did both anterior and posterior fixations with 360-degree fusion. So then, as I said earlier, so if the patient is presenting with Asia A or with a complete neurology and with spinal shock, and we understand the prognosis is not going to be good even after 48 hours where the spinal shock is setting out. So in these type of cases, what I learned initially, I did the both anterior and posterior approach, but then we realized that there is no point in operating these patients 360-degree unless we get a good outcome. So in that case, we discuss with the patient's family and we explain them the situation, and then we do the best for them. So either we go anterior approach only, or we do the posterior approach only in some situations. So this is such a case. This is a bull attack of 37-year-old male presented with spinal shock. He was initially unstable, so we couldn't do the close reduction in this patient, and we had to wait until the spinal shock settled. And he was persistently Asia A, and he developed aspiration pneumonia very early. So we had to do a tracheostomy as well before the surgery. And then we did the posterior only approach for this one. So 2, 3, 4, 5. This is 5, 6 dislocation. I know there is a disc in this case. There is, you can see the disc prolapse as well. But due to extensive soft tissue, PLC injury, posterior ligamentous complex injury, I decided to do posterior only approach. So this is what he ended up with. There was a good reduction and good alignment. And I had to fix him from C3 to all the way to T1 because there was extensive posterior ligamentous complex injury in this patient. So this is the pre-op and this is the post-op, you can see. Right. I'm sure
May I say something, dear Suraf?
Yeah.
Very interesting cases. It will be a help also for you to rest for a minute. Very important cases, compliments. You mentioned the role of the physical rehabilitation, a very important role, a role as important as the surgery itself. We said we have the same problem also in my country. We perform good surgeries, but after the outcome, and I also say to my residents, take care after the patients, because We lost the patient from internal medicine problems, such you mentioned, a good surgery that you perform that you lost from pneumonia. The physical rehabilitation is a very important thing, a very important issue, and maybe all the states, all the governments has to build hospitals, but to build also rehabilitation, appropriate rehabilitation centers. Because the main goal of these operations that you do very well, compliments, it's to preserve a minimum of quality of life and health-related quality of life in these patients that they are severe traumatized by accidents, by falls, by accidents, by, I don't know, war problems or violence problems. This is our main goal, to preserve a little bit of quality of life, to move, to go to the toilet, to have a real life themselves. And if they are young, under 50 or 40 years old, this is another important issue to help young patients, okay? Such a small comment, okay? Please continue.
Thank you very much for the comments. I completely agree with you. So, I mean, it's a big problem worldwide, whether you are in an affluent country or whether you are in a resource-restricted country, as we said. Right. So this is, again, you can see, yeah, this patient, you can see the complications. You can see this is immediate post-op, and you can see the whole lung, the left lung is collapsed. This is after 10 days. And again, he was just recovering. So this is him at 1 month post-op on a tracheostomy, and very minimal improvement neurologically. So this is at 1 month, and this is at 3 months. So you can see it's wasted, still on a tracheostomy, not much improvement. So that's what we said. The quality of life is not that great, right? So another patient, another case, we went only posterior, 66-year-old male, fallen from a height, again fallen from a tree, Asia A. He has a past history of bypass. Patient was on spinal shock. And again, we decided to select the posterior only approach. So 2, 3, 4, 5, 6. So this was a bit difficult case, and with locked facets. So we decided to go from the back, the posterior approach, and this is what we achieved. So we fixed him all the way to T1, and the facets and the lateral masses were broken, so we couldn't insert even the lateral mass screws at C7 level. So this is the post-op image, and again you can see the post-operative period is complicated by pneumonia. Right. So again, the patient ended up in a tracheostomy. Another one, 23 years of male, motor vehicle accident, again Asia A, spinal shock. So we decided to go from posterior approach only. 2, 3, 4, 5, 6, 7, 6, 7 dislocation. And this patient was it's very poor, and he couldn't afford the screws as we liked. So this is the pre-op CT, the axials. And this is what we did. So we approached from the posterior aspect, and I applied lateral mass screws as well as the cervical pedicle screws to this patient, because I had to use a minimal amount of the hardware, as this patient could not afford as much as we liked. So lateral mass screws are not available in the hospital, so the patient has to buy that, whatever it is, the lateral mass or the pedicle screws. So most of the patients, it's difficult for them, so we have to use the minimum number of screws. So this is what we did: 2, 3, 4, 5, 6, 7, 6, 7. So sometimes unilateral fixation rather than bilateral fixation. That is to use the minimum number of screws and to achieve the maximum stability and the biomechanical strength. Another one, this case was done today morning, C71. C71 fix dislocation. So you can see 2, 3, 4, 5, 6, 7. So bit of uncommon case. So this is I have done only 2 cases of C71. Patient was in spinal shock, so obviously junction. So I prefer posterior approach, and this is the axials. You can see this is what we did today. So I did C6 lateral mass, C7 pedicle screws, and T1, T2 pedicle screws. And it is very difficult, especially these type of patients at the junction, because you don't see, you don't visualize through the x-rays. I mean, most of the times you can't see, you have to go freehand. And especially in a short neck, this was a short-necked patient, bit obese. So consider the body habitus as well. So it's really difficult sometimes these cases. And these are few cases where I don't have the post-operative images. I have misplaced them. Again, C6-7 dislocation. You can see most of our cases either C6-7 or C5-6. Another case, 2, 3, 4, 5. This is a little bit higher, 4, 5. Again, we did these cases. I did only, I can remember this one, I did only anterior only approach. And this one, we did the 360-degree approach. So that is all about bifacet dislocation I have to show you. And so let's talk about a few cases of unifacet dislocation as well. So this is 18 years of male with motor vehicle accident with intact neurology. So what we did was the anterior approach first. This patient I did a corpectomy because we did not have anterior cervical plates for this patient during that time. So there is no point in just doing an ACDF without plating this type of cases. So I had to do a corpectomy with the expandable cage, which was available at the hospital. And then I had to do this posteriorly as well because of the ligamentous injury, significant ligamentous injury. So I did the posterior fixation as well. So this is the initial, the approach, the anterior approach, and the expandable cage was inserted, and then followed by the posterior approach as a staged procedure. After 1 month, I did the posterior approach. Unfortunately, MRI was not available at that time for me. Another case, again, young patient with intact neurology motor vehicle accidents. Again, this one, you can see 2, 3, 4, 5, 6. Yeah, 2, 3, 4, 5, 6, 7. Yeah, 6, 7 dislocation unilateral. But again, you can see a lot of posterior ligamentous complex injury with posterior element damage. So in this case, I wanted to go initially with an anterior. I wanted to do the anterior approach initially, but again, I did not have these anterior cervical plates. So as you understand, there is no point in doing just removing the disc and putting a cage. So you need to fix it. So first, I did the posterior approach, considering this, and I planned the second as the anterior approach as the second stage. But ideally, it's, as we know, it's not the ideal way according to the guidelines or whatever the evidence. But that's what I'm always telling you. Depending on the circumstances, you might have to change your decision, but you have to always think about patient safety and the patient's outcome, and do whatever which is most appropriate. So So I did it posteriorly. Again, this patient, could not afford the lateral mass screws, whatever. So what we had only 2 pedicle screws and 3 lateral mass screws, so I had to use it selectively. So I know this is not the ideal, but depending on the circumstances, so depending on what is available for you, we had to take the maximum benefit out of that. So this is what we did. T fixation of T1. Unfortunately, you can see the curvature was a little bit reversed in the final X-ray, which is not good, but such things happen. Right, so this is the post-op CT, and he's awaiting the second stage or the anterior approach when the plates are available. Again, another case, this is the last one, female, 33 years of age. Again, unilateral dislocation, is neurology intact. So just the anterior approach was enough in this patient. So this is what we did. And she did very well. And she was neurologically intact, and she has no problem up to now. So that's all I have got. You have any comments, Nick?
I'm sorry, Nick had to leave, Sarath. Thank you very much. And I'd like to open the floor to any comments or questions. Okay, let's see here. We have some shy attendees. Mansoor, do you have any comments or questions? I know that you communicated with, and everyone, including Mansoor, can type questions. If you're a little shy and you'd rather not appear on the camera, that's fine. Just text in your question or comment. Now, as a non-neurosurgeon, I just have a general question. Do you see a lot of these patients with dislocations of the cervical facet?
What's the question, John? Do
Do
you see?
you see a lot of patients, or just a couple a month or a couple a year?
No, that's what I said. So all these cases I have done during the last year. So for the last 1 year, I had done 16 cases of bifacet dislocation, which is quite a significant number.
Oh,
when
wow.
when you
And that's
consider
over a period of what time?
over 1 year.
1 year, that's a
12
lot.
months.
That's
Yeah.
a lot. I imagine they're not isolated injuries. They're usually associated with other types of injuries. Significant.
Yes. Some people presenting with abdominal injuries, chest injuries as well. But most of the cases I showed you are mainly isolated cervical spine injuries with minor head injury.
Okay, very good. Very good. Okay, I guess if no one wants to comment or question, I'd like to thank you for the presentation, and
John, can I?
Go ahead, sure. We'd love to have some feedback.
Yeah. My mic was not ready, so I got it late. So myself, Dr. Rahul, I'm from India. So we do also see a lot of the cervical injuries. So basically, the first point I wanted to ask is regarding the closed traction. So regarding closed traction, what usually we follow is like most of the skull tongs are not MRI compatible. So what we do is, if a patient is not in a spinal shock, we get the MRI fast as soon as possible, and then we see, and then we put the tongs. But unfortunately, if patient comes with spinal shock, then we don't, we don't push it for the MRI. We wait for the spinal shock to settle, and most of them will require this tong to be set and in traction. Even though it might be reduced, it can still come to the original position. So it has to be in the continuous fashion till we take and do the open retention. That's what I think. That was one doubt I had. So you said that you will put the songs and then shift to MRI and then do the thing. So I had a doubt like how the tongue is MRI compatible. So basically that.
No, no, actually, what I told was, I mean, not in my setup. So what that was what I feel that should be what should be done. But unfortunately, in my setup, what happens is most of these cases I did without an MRI because we did not have an MRI in my center. So the MRI was out of the way. So in some cases, I had to go for a close reduction initially because, I mean, no option. And sometimes, as you correctly mentioned, yes. So we had to keep the continuous traction and then go for the open reduction.
Yeah. So second question was like regarding this higher cervical injury. So most of them will have this phrenic nerve, of course, phrenic nerve involved. So what I have seen started in India recently, they have started is they started doing phrenic nerve stimulation, pacing for the phrenic nerve at uh, in an early stage, in an early manner, at least 2 weeks or 4 weeks post injury, so that the muscle does not get denervated. We don't wait for longer enough in a good patient, young patient, and the phrenic nerve is there. At least we can avoid all this complication due to tracheostomy, basically. And we lose lots of them due to this respiratory, repeated respiratory infection, all those things. So
yeah,
that is the one of the questions. And unilateral is, of course, unilateral dislocation is very, very difficult to reduce. Even I have also tried, even if you see intraop also, it might be looking like it might have reduced. It's very difficult for the C-arm to still see that fluoroscopy.
yes, yes,
But
completely.
even you can completely, even if you just in situ reduction, just put the cage and come out also, it's okay, I think. Even if you fix it in the same position also, it's not going to make much of a difference, I think. Unilateral, basically. Only grade 1. So,
Yeah,
and
I mean
what
that.
is the steroids? Do you give steroids in your country? And how about like those all these patients? Steroids. Do you use
Steroids?
steroids? Yeah, steroids.
No, I initially did not use the steroids, but then after some time we decided to use the methylprednisolone according to the feelings suggestions. So that is again recent. But to be honest, I don't see much of a difference in this patient. So I personally don't like to use steroids in these patients.
And since you follow the AO principle, so they 2016, if you see 2016, they have come up with a subgroup analysis. Steroid is beneficial according to their point of view now. So that is why I was asking regarding.
Yeah. I also follow the guidelines. And you mentioned a very good point regarding the phrenic nerve. Unfortunately, it's not available in my setup.
We should
So
stop. Then only we'll retard this patient being and dying due to repeated respiratory. I think that's the only solution, I think.
yeah.
That's the only solution to go ahead.
Yeah, how was the outcome like in your patients? Those patients who underwent.
Most of them, we also had the same number of problems. They used to succumb due to like after 6 or 7 days due to edema, rising edema to the upper cervical cord. Most of these injuries, C5, C6, and all grade 3 diseases.
Yeah.
So we also had almost similar kind of complication as you mentioned. But our rehabilitation is one of the finest here. So I work in CMC Vellore. So you might have heard about that.
Yeah, I have heard it. Yeah.
CMC Vellore has a good rehabilitation center. So basically, due to rehabilitation, we don't see that much of that, and that as you see, probably from I think from your 16 patients, almost 4 or 5 you had mortality, right? 4 or 5.
Yes. Yeah.
We might not see that much, but yeah, definitely if they succumb to respiratory problems and the raising spinal cord edema.
Yeah. What about regarding the approaches? Do you do, I mean, what is said in the guidelines as anterior and posterior, or you prefer just anterior, posterior?
Mostly it is anterior and posterior. The hospitals where I worked before, they used to do only anterior approach and most of this. And I would still say that still, I don't see much of a graft extrusion as used to. That is mostly implant related problems, I think. It's not due to your technical fault. It might be just the implant related problem. Sometimes the screw is, the screwdriver does not fit the screw and you don't get the haptic feedback due to those things, I think. Most of it is due to the implant, what you showed one of the cases probably. And yeah, otherwise, we also have almost same. Your question was what exactly? I just forgot.
No, I mean, do you consider posterior only approach in your setup, or
Never consider. It is always a combination. It is always a combination or anterior approach. It is never posterior alone.
Right. Because in some centers, I had a surgeon from a neurosurgeon from India, and he also said that they mainly do what is, I mean, they do posterior approaches. And initially, I also thought the other way around, because you should do the anterior approaches. But in my setup, what happens is I don't have these hardwares most of the times to go for anterior plating, because there is no point in just doing an ACDF without plating them. So I mean, reluctantly or not, I had to go for posterior approaches in such cases. So yeah.
But seeing your list of surgeries, I don't think posterior is also so bad. You can still escape with just posterior one approach.
Yeah.
Thank you.
Thank you very much for the comments.
Okay, we have a question from Mansoor Ali Sutton Khan from Hyderabad, India, a neurosurgeon, I believe. He has a question that, let's see, let me get it here. What decides to choose which approach to be chosen?
Yeah, so that's why we showed that flow chart. So if it's a bifacet dislocation, mainly depending on whether there is a disc protrusion or not. So if there is a disc protrusion in the MRI, so mainly we go from the anterior approach. If it's a bifacet dislocation, you go anterior plus posterior. So if not, mainly nowadays the trend is to go for the anterior approach only rather than the posterior approach, as it was in the past. So so there are so many factors to decide whether it is at anterior or posterior or anterior plus posterior. So as I mentioned, so the main components are whether there's a disc or not, disc protrusion or not, and also the neurological, the severity of the neurological injury, and as mentioned, the level of the injury, and the body habitus of the patient, the surgeon preference, surgeon's experience. Those are the various factors which determines which approach to use. But according to our guidelines, you could see it's mainly depending on the disc.
Mansoor, any follow-up comments to Sarath? You can just text them in.
Yeah, sure.
Oh, I guess he's not texting any follow-up comments. No, okay. Any more comments or questions? Because when I always say I'm going to leave, someone pops up. No, okay, very good. I think, do you have any plans for a couple of weeks from now, or you haven't thought about it yet?
Yeah, I think we can connect Dr. Aish as well for the next one. I think he's in Japan at the moment. So planning to connect him as well for the next one. So next time we talk about the lumbar spine, some topic on lumbar spine.
Okay, very good. Very good. Thank you very much for the time and effort, Sarath, and for improving the education online for neurosurgery on this beautiful day. And we'll see you in 2 weeks.
Yeah, thank you very much, John. And just one thing, I would like to invite all my neurosurgery colleagues in Sri Lanka to use this platform to present their cases, and also all over the world, from anyone. I mean, they can take this opportunity and discuss their cases. They present their cases. They must be having some important rare cases. I mean, interesting cases. So they can bring the cases and use this platform to discuss. So it's an open invitation for everyone, especially the Sri Lankan neurosurgeons.
Great. It's a great platform for education. It's meant to be shared, and it gets more powerful when you share it. So you're going to be improving the general knowledge of neurosurgery the more cases you present. Right, Sarath? Okay, then.
Thank you very much, John.
Thank
See
you.
See you in 2 weeks' time. Bye.
Okay, I'm going to stop here.